Hello, everyone. My name is Frédéric Michard, and I'm from Lausanne in Switzerland. And so before I start, I'd like to disclose the fact that I'm today leading a consulting and research company based in the Swiss Silicon Valley, where we focus on digital innovations with medical applications. So pulse oximetry was invented in the 70s by Mr. Takuro Aoyagi, who sadly passed away a few months ago. And it is used far beyond the OR and the ICU to monitor oxygen saturation. It can also be used to monitor pulse rate, to monitor the peripheral perfusion index, to monitor the place variability index, which is nothing else than the quantification of the respiratory swings in the pulse oximetry waveform, to track changes in hemoglobin during surgery, and so on and so forth. In this presentation, I'm going to focus on new applications having in mind COVID-19 patients. So first of all, home monitoring. If I had the opportunity to look inside your medicine cabinet, I would probably find a thermometer, possibly a brachial cuff, but I'm not sure I would find a pulse oximeter. And that would be a paradox because pulse oximeters are actually devices easy to find today and usually affordable. And this is here just an example of what we can find here in Switzerland when searching for wireless pulse oximeter on the web. For patients who test positive for the coronavirus, the new coronavirus, it may make sense to monitor from time to time SpO2 from home. There are actually devices which are also able to monitor respiratory rate or even PVI. And I will say in a few words in this presentation a bit later about the potential value of PVI in spontaneously breathing patients. But of course, some patients are, I would say, unable to do it by themselves. And so there are more and more remote monitoring initiatives going on, particularly in the US, where patients are wearing a pulse oximeter, a wireless pulse oximeter that is connected via Bluetooth to their smartphone. And then, of course, through an application, the smartphone is connected to a command center where technicians or clinicians are able to provide advices. Another application is the continuous monitoring of SpO2 on the wards. Today, in most patients who are on the medical wards, nurses are doing spot check of vital signs only every 4 to 6 hours. And so because of the intermittent nature of this spot check, we know that they may miss a significant proportion of adverse events. And this study is an illustration. It was done at the Cleveland Clinic a few years ago. And they realized that when monitoring SpO2 continuously, nurses were actually missing up to 90% of hypoxemic events when simply relying on intermittent spot check done every 4 hours. So clearly there is value in monitoring SpO2 and pulse rate continuously, and several studies have demonstrated outcome benefits now. This is the very first and the landmark study from Andreas Tenzer, published in Anesthesiology, where they monitored a large number of orthopedic patients after surgery, and many of them are receiving opioids. And what they reported is a significant decrease in the number of rescue events. You see on the left-hand side of the slide, the unit where they implemented this continuous monitoring of SpO2 and pulse rate. So a significant decrease in the number of rescue events as compared to what was observed in control unit 1 and control unit 2. They also reported or observed a significant decrease in the number of ICU transfer, and it makes sense to believe that if we can detect clinical deterioration at early stage, we can probably prevent, if not all, at least some ICU admissions. In the study, they used a wired pulse oximeter system, but today there are wireless systems which are available and may help to monitor patients on the wards. What we can do as well on the wards with SpO2 monitoring is to use the SpO2 value as the input variable for an automatic system, a closed loop system delivering oxygen, adapting oxygen flow to oxygen needs. Such system now exists, And this is here the example of a recording. At the top, you have the SpO2 values, and you see the target range in this patient was 90% plus or minus 2.5. And at the bottom, you see the variation in oxygen flow, which is automatically adapted to ensure that SpO2 remains within target. So such systems are useful to optimize the time spent within target. And studies have shown they are also useful to decrease the duration of oxygen administration and even to decrease hospital length of stay. PVI, so I already briefly mentioned that we could use PVI in spontaneously breathing patients. You probably know PVI as surrogate for PPV in patients who are mechanically ventilated. But in spontaneously breathing patients, the respiratory swings in the pulse oximetry waveform depends more on the respiratory effort, on the respiratory swings in pleural pressure or intrathoracic pressure, than on the volume status of patients. This is the reason why PVI has been described as an important sign of upper airway obstruction, because when patients are making significant expiratory effort, you will indeed observe large plethysmographic variations with respiration. And it has been suggested it could be used as well to assess the severity of asthma crisis. Clearly, in patients who develop acute respiratory failure related to pneumonia, to ARDS, or to COVID-19, we could also envision to use PVI to assess this time the inspiratory effort of these patients. And I don't know if you have seen this recent publication in the Blood Journal by an Italian group, Tonelli and co-workers. They measured the esophageal pressure and they tracked the changes, the respiratory changes in esophageal pressure to assess the inspiratory effort in patients developing de novo respiratory failure. And what they showed is pretty interesting. When we start non-invasive ventilation in these patients, there are basically two different patterns. In some patients, after 1 hour of non-invasive ventilation, you observe basically no change in the respiratory effort. And these patients are actually ultimately intubated. In contrast, in patients in whom non-invasive ventilation is a success, if we look at the respiratory effort, the quantification of the respiratory effort, by measuring the swings in the esophageal pressure, we observe a dramatic decrease. So, in other words, this study suggests that quantifying the change in respiratory effort during non-invasive ventilation, or probably as well during high-flow oxygen therapy, is a way to predict the success of non-invasive ventilation and may help in the decision-making process of tracheal intubation. The problem, and honestly it's a big problem, it's a big issue, that we do not usually measure the esophageal pressure in these patients. We do that just for research. So with Kirk Shelley from Yale University, we thought that we could possibly use actually the place variability index, the pulsus paradoxus, the quantification of this phenomenon to assess inspiratory effort and then guide in the decision or help in the decision-making process of tracheal intubation. Another application is related to the use of the perfusion index, the peripheral perfusion index, which is very often simply used as a quality indicator. If you track changes in perfusion index during a passive leg raising maneuver or during a lung recruitment maneuver, you can actually predict fluid responsiveness. So as already mentioned, that PPV and PVI are used frequently to predict fluid responsiveness in mechanically ventilated patients. But if you use a low tidal volume, which is the case in patients with COVID-19, if you use protective mechanical ventilation, you will have false negative. So it's clearly not a situation where you can easily rely on PPV, SVV, or PVI values. So what can be done in that case is a passive leg raise maneuver. You're going to mimic the effect of fluid administration without the need to give a single drop of fluid. And this is typically what you observe if you monitor cardiac output continuously at the same time. For instance, with a pulse contour technique, you see in this example a significant rise in cardiac output during the PLR maneuver, indicating the patient is very likely fluid responsive. And indeed, when fluid was given, you see a dramatic increase in cardiac output. The thing is that many patients, we do not measure cardiac output continuously. And so maybe tracking changes in PI may be used as a surrogate to or for changes in stroke volume. So the perfusion index is a pulsatile component of the pulse oximetry waveform. It is measured by most pulse oximeters today, and as I mentioned already, is actually mainly used as a quality indicator. But this variable is actually meaningful. It depends on vascular tone and sympathetic activity. It depends as well on blood flow and stroke volume. So if we can imagine situations over a short period of time where vascular tone doesn't change, we could imagine that tracking changes in PI may give us information about changes in stroke volume. So that was the hypothesis made by the group of Jean-Louis Teboul and Xavier Monet in this study published last year. And so they recorded changes in PI during a passive leg raise maneuver. So in the study, they also monitored cardiac output. And you see at the top changes in cardiac output during the passive leg raise maneuver and then during the following volume expansion in this fluid responder patient. And you can notice that at the bottom, the PI, the perfusion index, dramatically or significantly increased during the PLR maneuver in this patient. In contrast, it's a non-responder patient. You see no change in cardiac index during the PLR, so no change in cardiac index during volume expansion. And interestingly, in this patient, our PI didn't change during the passive leg raise maneuver. So tracking changes in PI may help you to predict fluid responsiveness during a passive leg raise maneuver, just from the pulse oximeter. The sensitivity was pretty good. The specificity was acceptable. And so that's probably something we can do or we should do more often at the bedside. What we often do as well in patients with acute respiratory failure to open the lungs or to keep the lungs open is our recruitment maneuvers. And we can also learn from a hemodynamic standpoint from these recruitment maneuvers. This is at least what was suggested by this study from Mathieu Bier and co-workers published a few years ago in anesthesiology. They quantify changes in stroke volume during a lung recruitment maneuver and describe two different patterns. In some patients, on the left-hand side, they observe a dramatic decrease in stroke volume. In other patients, they observed only a slight decrease in stroke volume. And they were able to show in that study that patients on the left are actually fluid responders, whereas patients on the right are not fluid responders. The best cutoff value to discriminate between responders and non-responders was a delta stroke volume of 30% in this study. So let me show you an example to understand how it works in practice. If you do a recruitment maneuver, you increase the airway pressure up to 30 centimeters of water for 30 seconds. So you see in green, you have the peak airway pressure. And in blue, you have a stroke volume index recorded simultaneously and continuously by a pulse contour technique. And you see that during, in this patient, this specific patient, for example, during the lung recruitment maneuver, stroke volume decreased, but only slightly, by less than 30%. And you see that when this patient received fluid, stroke volume didn't change. In contrast, here you have an example of fluid responder patient. During the recruitment maneuver, you can see a dramatic decrease in stroke volume by more than 30%. And you can see as well that when the patient received fluid, it was associated with a progressive increase and significant increase in stroke volume. The thing is that, as I mentioned already, we do not always monitor stroke volume. And so the idea we had with Mathieu is maybe to use changes in PI during a recruitment maneuver to predict fluid responsiveness. And indeed, it worked pretty well. As you can see on this graph, patients who were fluid responders actually had or experienced a dramatic decrease in their peripheral perfusion index during the lung recruitment maneuver. So this is a non-invasive and easy way to detect fluid responsiveness if you are not monitoring cardiac output continuously. The sensitivity and specificity were not perfect, but the predictive value was clearly far above what you can expect from a classical parameter or variable like PPV in this context of protective mechanical ventilation. In addition, we believe this is something that could be easily automatized by the next generation of mechanical ventilator. I mean, when they will do automatically a lung recruitment maneuver, they would have potential, assuming they also monitor SpO2, to assess the impact on perfusion index and then tell you if the patient is fluid responsive or not. Last but not least, we can envision to track changes in blood pressure, just looking at pulse oximetry waveform. So it's a pretty new concept. And you may have seen this recent paper published by the group of Patrick Schottker with Yassine Gamri from the University Hospital of Lausanne and colleagues from the CISM in Neuchâtel. What they did is actually they used a machine learning system, and they fed the system with a large number of pulse oximetry waveforms and simultaneous blood pressure measurements. And so the system was able to learn and to recognize specific patterns or phenotypes or signatures, if you prefer, of a decrease or a rise in blood pressure. And then when they used or tested the software in a clinical situation where there are dramatic changes in blood pressure, anesthesia induction, they were able to show their software was pretty good, pretty accurate at detecting changes in systolic pressure here on the left-hand side or changes in mean arterial pressure here on the right-hand side. So in conclusion, we can use pulse oximetry from home, ambulatory monitoring, self-monitoring at least twice a day with a miniaturized pulse oximeter. It's easy to do. And it should help to rationalize hospitalization, to trigger hospitalization as soon as patients deteriorate. We can use pulse oximetry on hospital wards for continuous monitoring. It enables the early detection of clinical deterioration, and we know it's good, it's useful to improve outcome. We can use SpO2 as the input variable for closed-loop system that will deliver automatically the right oxygen flow. And finally, we can use PVI to quantify the respiratory efforts. In the ICU, we can continue to use classical pulse oximetry devices or solutions, but we should think about the possibility to predict fluid responsiveness, assuming cardiac output is not monitored. If you track changes in PI during a lung recruitment maneuver, you can also predict fluid responsiveness. With that, I thank you very much for your attention. And in case you are interested in the topic, I invite you to read these two articles we recently published with Kirk Scheller, with Erwan Ler, with Bernd Sogel, and Benoît Vallée. Thank you very much for your attention. Thank you.